Hello, my name's Mariah Campoy, and I'm going to be talking about Orthorexia Nervosa today with Nora Hall. Some of our objectives today will be, one, to define Orthorexia Nervosa. Specifically, the goal is to help healthcare professionals understand the disorder and the differences between it and anorexia nervosa, discuss risk factors and prevalence of ON, provide an example presentation and treatment plan, and discuss the success rate of the recommended treatment plan. So our audience question will be, what is the main difference between anorexia nervosa and orthorexia nervosa? Keep your ears open, that way you will know the answer to that. So simply put, the definition of orthorexia nervosa is a condition described as a pathological obsession with healthy eating. So pathological meaning it is having effect on your physical or mental well-being. So orthorexia nervosa, that is the key component. Of course, we can all obsess over healthy eating, but once it starts affecting our mental health and our physical well-being, it becomes a disorder. So chronic disease has risen rapidly over the last decades, actually. So there's always been a need for health education. As the need is being met, there are more people who start to obsess over their health. It may cause anxiety. It may cause, fear of gaining weight. And so that leads us to orthorexia nervosa. It was proposed by Bratton in the late 1990s. He discovered there were individuals who were obsessed with eating healthy, and it was actually leading to malnourishment, and there have been cases of even death. Although it was just mentioned, in the 90s, there still isn't enough criteria that has been created to create a diagnosis of ON. Therefore, it does fall under the umbrella term of avoidant restrictive food intake disorder. So if you do get a patient with ARFID, it's good to determine, exactly which disorder they may have so you can properly treat them. So as health becomes more and more important in younger generations, it's important to shine a spotlight on ON. This may be something that becomes more prevalent moving forward. So some risk factors of developing ON would be like a perfectionist personality, so OCD. These patients or clients are at higher risk of, being concerned about their health and obsessing over their health. History of a mental health disorder. If you have a history of anxiety, it may cause more anxiousness to think about health and even food avoidance. History of eating disorder, of course, but a history of disordered eating, which has not been diagnosed with an eating disorder, is also something to look for. Someone who's constantly dieting, maybe they've been dieting their whole life. Someone who may have a poor body image. That's going to be the main difference between orthorexia nervosa and anorexia nervosa. In anorexia nervosa, there is a distorted body image. So these patients literally see that their body, there's something wrong with their body. We don't see it. We see a normal body, but in anorexia, they have that image in their head. With orthorexia, there's no image. They can see themselves. They just want to be thinner. And when they do reach that thinner state, they're content. And so that's the difference with ON, is that they don't have that distorted body image. They will be content, or maybe they won't, but they don't have that distortion in their mind. So the other thing to know is the prevalence. So there was a study done by Dunty et al. In 2016 on 275 participants where they were trying to determine what the prevalence of ON was in that population. They did find that 1% of the sample fell into the category, which is low as expected with eating disorders. They used the ORTO15 survey to determine this, which has shown good results. The only problem is that it does categorize vegans and healthy eaters in the ON category. So they did have to adjust for that. It also did only look at college students. So that's a very specific population. So it would be interesting to see what this would be if it was done on a broader population. All right, so last thing would be client presentation. And so it's very important as medical, I'm a healthcare provider, so understanding what the client presentation is, but most healthcare providers are not going to know what ON is. And so it's important that dietitians also know how ON may present, which I'm sure they do. But just in case, these are some good tidbits to remember. The person may or may not be underweight. If they are underweight, they're dealing with severe ON. They may follow a strict lifestyle, veganism, vegetarianism, paleo. They may be constantly dieting. They may be a picky eater. So if there's a family there, probing them to see if they have any history they can provide you as well. Maybe the person avoids eating out. Maybe they make comments about the family's eating patterns. Maybe they even flaunt their healthy choices. Again, ON clients and patients tend to be proud of their diet. They are more vocal than anorexia nervosa patients. So these are things that you do want to pick out so you can properly determine which disorder the patient or client is suffering from. All right, so now I'm going to go ahead and leave it to Nora, and she's going to finish off the presentation.
Here is an example of a gentleman who is being evaluated for orthorexia nervosa. Mr. P is 30 years old. He is 5 feet 10 inches tall and he weighs 145 pounds. His recommended weight range based on the Hamway equation is between 150 to 182 pounds. So he is slightly underweight, even though his BMI is technically within the normal weight range. He has eliminated foods and food groups. He has anxiety about his diet and his food intake. He is experiencing guilt and shame with what he calls slip-ups, and his sodium is registering at 130 MEQs per liter, which is low, and his electrocardiogram is revealing bradycardia, which is a slowed heart rate. Mr. P's recommended treatment plan would be multifactorial. In this situation, inpatient treatment may be necessary to address his medical concerns and would be the short-term treatment goals. His treatment could transition to outpatient when he is no longer experiencing those acute medical needs. The long-term goals would address his anxiety and obsessive compulsiveness regarding his food intake. In general, treatment recommendations would be for a multidisciplinary team approach. There are no official clinical treatment recommendations for orthorexia nervosa as it is not officially recognized by the DSM-5. Many eating disorder treatment centers will treat orthorexia nervosa similarly to anorexia or obsessive compulsive disorder. Treatment should be multifaceted in order to cover the psychological, physical, and emotional components of orthorexia nervosa. Personalized treatment should be offered according to each individual's needs. Here are some of the common barriers to treatments: denial, failure to perceive the severity, shame, lack of encouragement or support from loved ones, lack of knowledge about resources, cost of treatment, negative attitudes towards seeking help, and low motivation for change. Individuals who saw that their healthy eating was problematic were more likely to have a perceived need for treatment than those who did not. Inpatient treatment for eating disorders in the US ranges from $500 to $2,000 per day. Long-term outpatient treatment, including therapy and medical monitoring, can cost upwards of $100,000 or more. Since orthorexia nervosa is not recognized by the DSM-5, many insurance companies may not be willing to cover treatment. While there is not information available about the treatment successes of orthorexia nervosa, treatment success rates for general eating disorders could apply. According to statistics, 60% of individuals who come for professional eating disorder treatment will make a full recovery. Treatment is most successful when intervention is early. Treatment is most successful when it is multifaceted, and long-term treatment is often needed as eating disorders require ongoing care. In summary, although diagnostic criteria for orthorexia nervosa is not specifically covered by the DSM-5, there is a growing need for official clinical treatment recommendations. Many of those who struggle with orthorexia nervosa may not recognize that they have a problem or need treatment. The initial desire to eat healthy or to be healthier can shift into orthorexia as foods and food groups are eliminated and healthy behaviors begin to cause elevated stress and anxiety. Official recognition of orthorexia nervosa would allow for better insurance coverage for treatment and would provide individuals with a better understanding of its seriousness and its impact on physical and mental health. This concludes the introductory webinar about orthorexia nervosa. We hope that you have learned more about orthorexia nervosa in general, and especially the need for official diagnosis criteria. We would urge the American Psychiatric Association to include orthorexia nervosa in the next version of the Diagnostic and Statistical Manual of Mental Disorders. Thank you.